I'm Lindsay Hughes, Director of Operations at Primary Care Sheffield. So the NHS long-term plan is to advance mental health equality, and as part of that there was a requirement for mental health to transform. That's across a host of mental health services, of which PCMH is just one. So PCMH stands for Primary and Community Mental Health Services, and this service is run in partnership between Sheffield Mind, Sheffield Health and Social Care NHS Foundation Trust and Primary Care Sheffield PCS. So Primary Care Sheffield got involved in this because it was really clear that in Sheffield we wanted to do something different with this mental health service. So although the long-term plan was encouraging people to advance mental health equality and make sure people with serious mental illness could access treatment services, as historically talking therapies, previously known as IAPT, wasn't able to take people with serious mental illness and do the things that they do with them. So this service was set up to work with people with serious mental illness. So Primary Care Sheffield got involved because we were really keen that this service in Sheffield really integrated with neighbourhood teams and that it had a primary care focus. If you talk to colleagues in other areas of South Yorkshire, they'll talk about a secondary care provider providing services into their practice, but a lack of primary care engagement and influence on that service in the way that it's run, and it's certainly not run in System 1 modules. So that's why Primary Care Sheffield got involved in this transformation. So the PCNR's money, obviously there's lots of different ways you can spend the PCNR's money. The money that's attributed for mental health practitioners is slightly different. So that money, you can't recruit those roles. So PCNs can recruit pharmacists, OTs, all sorts of other roles, but they can't recruit the mental health practitioners. And that's because the NHS thought, we're doing this transformation over here where we want better equality for patients. At the same time, we want that to connect to primary care. So what better way than to use the R's funding to ensure that 50% came from a central pot, 50% came from the PCN, and that the roles were hosted centrally. So for your roles, you get a little bit of flex on that serious mental illness. So PCMH is contracted to deliver therapeutic treatment pathways, which can include different roles, not all of them are clinical, for people with serious mental illness. By adding your funding and putting in your ARS funding, you're able to blur those boundaries a little bit, and we can talk to people who have ongoing mental health issues that have lasted over 6 months but haven't necessarily got a diagnosis of serious mental illness. So for those practices that are putting that extra funding in, you get additional capacity, and because you're putting that additional capacity in, you also get a little bit of the blurring of the boundaries. For those PCNs that are not putting the funding in, you are looking particularly at serious mental illness, those with those diagnoses, and you will get the funding that's been allocated centrally. So this service has been one of the first nationally to start using measures. So we use a measure called REQUAL, and this measure looks at the quality of life of the patient. So we don't just do it at the beginning, we also do it at the midpoint and towards the end, depending on how long the patient is with us. And the difference that we measure is between the first point and the end point. And the aim is obviously that that patient's quality of life has been improved by the work that we've been doing with that patient. So any improvement is obviously great because that measure could go backwards, it could be a minus number. But statistically, the area that's really the sweet spot is if we can move that quality of life measure up by more than 5 points. So obviously how we're doing as a service does flex a little bit. We've been as high as nearly 7 and just about 6 as well, but we're always above that 5 points. So we've continually delivered since we started measuring a service that we can demonstrate we're improving the quality of life of those patients. So that's how we feel we can show you that the service is working. We also measure as you do yourself, friends and family, and we have some other measures called dialogue and other things. But I think the REQUAL is the really important measure in showing that that patient's quality of life has improved. So one of the benefits of us being in a partnership is that we try to work together as a system to make sure that the patient gets to the right place. Obviously, the best thing that could happen is the patient to get to the right door first time. But we recognise sometimes that can be really difficult to decide where that patient goes. So if, for example, a patient ended up with PCMH and they should have gone to CMHT, our team will see that patient. They will do the work with that patient, and then we have a couple of options. We can either talk to CMHT and pass that patient across, or we can take them to a huddle and have a discussion where we decide exactly where that patient should go. There's a lot of work going off in these huddles, and for those of you that have seen the service update recently, CMHT have shared their inclusion and exclusion criteria. The way that we can move forward and we can really start to ensure that the patients are getting to the right door and that we're not wasting any resources in different teams seeing patients only to hand them off to another team and sort of double handle that patient, is to try and help general practice have all the tools and everything that you need to be able to make the best decisions possible. So we've committed, as part of those events that we had last year, to really explore how we come up with something really simple where you can answer some questions and then know exactly which service to send that patient to. So we're working on that as a system, and we'll continue to develop that. We have got the questions for PCMH, and you'll start to see them shared as part of the medical model rollout, so our psychiatry offer and the pharmacies and all the other parts of that model. But we'll continue to work as a team to share that with you all. Thank you very much for your time.